but before we begin, I would like to acknowledge the traditional owners of the land on which we meet, the Ngunnawal peoples in my case, and extend that respect to any Indigenous people joining us today. So today's topic is all about sex, and it's a great topic because I feel like it's something that we generally talk to our friends about or we look up on the internet, but rarely do we actually go to a doctor to talk about sex. And in this case, I think having professional medical advice from two doctors is something that is extremely worthwhile. And so I would encourage you, if you have any questions about the topics that we'll cover today, which are STIs, abortion, contraception, and libido, to put them in the chat box, and our speakers will address them live or via the chat. And so I'll introduce our speakers shortly, and some of you may already be familiar with them since Dr. Talat Uppal and Dr. Nisha Khot were our first speakers in the Healthy Horizons series. And so Dr. Uppal is an obstetrician and gynaecologist who is also clinical director of Women's Health Road in Sydney. And we also have Dr. Nisha Khot, who is a Melbourne-based women's health specialist who also works at Western Health and Royal Women's Hospitals. So doctors, thank you so much for being here today.
Thank you for having us.
So today's topic is very much something people, I hope, are looking forward to, and we'll be starting off with contraception, since that's something that's very relevant to most people. And so Dr. Uppal, can you start us off by telling us what contraception is and what is its purpose?
So contraception is any method that helps a woman space or plan a pregnancy. So the most ideal situation is that babies are planned, and despite that ideal situation, only 50% of pregnancies in Australia are planned. And most of the times we have a number of options that are available for us to choose which one is more relevant for you. And I'd like to go through the various options. Some people prefer natural methods, and these are called fertility awareness methods. The problem with natural methods is that they do have a high failure rate. The other options are including hormonal or non-hormonal options. There are also options that depend on how we use them. Some women want to use it, prefer a tablet. Others want to fit and forget and have a long-acting contraception. So that's another group of contraceptives available to us that are a bit underutilized in Australia. We actually generally are trying to raise more awareness about the benefits of these long-acting contraception that could either sit inside your uterus or go into the arm as a long-standing implant. And finally, we have options that are, obviously we have the oral contraceptive pill, and there is an injection we can take every 3 months to stop the ovaries from ovulating. But finally, we have long-term, for women that have completed, and men that have completed their family, we have an option of permanent sterilization. And that is relevant to many couples who don't want to use hormones, or women that don't want to have anything artificial and want to have a long-term, they're certain that they don't want a bigger family size. So to recap, the natural methods may include things like, and it's really important, one of the important take-home messages is, please do not be confident of the natural methods. For example, like withdrawal outside the vagina. Many people think, oh, look, the partner ejaculated outside in a male-female sexual activity. But even before a person ejaculates or releases sperm, you can actually release small amounts of sperm. And that's why in typical use, up to a quarter of the times, it can fail. And that's a pretty high statistic. You don't want a quarter of the times to fall pregnant when you're trying not to. So those I genuinely feel that it's important. Some women try and isolate when they think they're ovulating and try and avoid sex in that period. But again, the issue is it's not a perfect art. Actually, none of the contraception is a perfect art, so nothing is 100% effective, but there are certainly options that are far more effective than the natural options. So the second group that we have are condoms. I'm sure you're all familiar with condoms. This is a typical male condom. And we've got female condoms as well that are available from chemists or from shops. And the good thing about condoms is they do protect against sexually transmitted infection. And we're going to go into that very soon. But let's always remember that there are two factors. One is about controlling your fertility and having a baby when you want it and not having a baby when you don't want one. And the second part is about protecting yourself against infections so that you're not vulnerable. And then because the infections that we're going to talk about can have long-term consequences. So the other part, so apart from barrier methods, another thing is called a diaphragm that goes inside and it basically goes next to the cervix and tries to prevent the sperm swimming up into the uterus and getting access to the egg, because the physiology is that the sperm want to surround the egg, and obviously one of them then fertilizes it usually, and then that's how a pregnancy occurs. So contraception is basically interrupting that process at one or multiple aspects so that it doesn't occur. This is another interesting type of a contraceptive that goes, for example, in an arm, and this is how we insert it. Basically, it's a little rod that goes in under your arm, and that allows, it stays there for 3 years, and it's a single hormone called progesterone. And for this, as well as something that we call an intrauterine device, I hope it's pretty obvious there. And Amanda, is that obvious?
Yes, we can see it.
Yeah, and so see how that's coming out, but in the actual uterus, there is an intrauterine device. And so both of these are long-acting contraceptives. We put them in to try and last between 3 years for the one that goes in your arm and up to 5 years for the one that goes in your uterus. The good thing about this is you don't need to take something every day. If you forget, you still, and it's very effective. So it's more than 99% effective, which means that it hardly ever fails. Amanda, do we have time to go into permanent sterilization? Or would you like?
We can talk briefly about it, but first to ask, would you recommend women use 2 forms of birth control always to be extra safe, or is one?
So like I mentioned, the condoms often are a good thing to combine because then they're giving you that added layer of protection. Otherwise, in general, we don't tend to typically layer the contraceptives because they're, either you put a Mirena or an implant, or you, but then some people may want to use a diaphragm and condoms. Nisha, do you think there are any combinations that we use?
I think it depends on the situation in which you are using the contraceptive. So if you are in a monogamous long-term relationship and that's the situation in which you are using contraception, then you don't need to layer it with anything else, as in if you have something like the Mirena or the implant, which is the rod. But if you are in a relationship that is not that kind, so if you have more than one sexual partner, if you're not in a long-term relationship, then it makes sense to protect yourself from those sexually transmitted infections. So it's important to use barrier contraception.
So yeah, Amanda, so yes, the general situation in which we combine is with a condom, with the lens of avoiding an STI in those situations.
Great, thanks Talat. And you mentioned as well permanent sterilization as an option. Can you talk briefly about that?
Of course. So for men, there is an option called a vasectomy, which can actually be done as an outpatient procedure, and usually there's a 3-month period before it becomes effective, but really, really good option. And also for women, there's an option of basically taking out the tubes or clipping the tubes, and this interrupts the sperm physically getting to the egg. And basically, you then don't need any hormones. It is done through keyhole surgery, usually, for us to be able to access the woman's tubes. But long-term, it has a low failure rate, and it gives women that peace of mind. Many of my patients say they've started to enjoy sex more because they're not stressed about falling pregnant. So ask your doctor. Your GP is a very good starting point in the contraception discussion, and then you can be referred to a gynecologist or to a public gynecology clinic. Access this help that is available for you, because on the other hand, an unplanned pregnancy basically does carry both physical and mental risk, and bringing up a child that wasn't, wanted, or it's another very complex space that it's best to try and avoid that if you can.
Wonderful, thank you.
And I would add that it's important to remember that you need contraception at every stage in your life. And often what we see is women, once they get past maybe 45 or, get close to menopause, they might not be thinking of contraception as the top priority, but actually you can still fall pregnant. And so
Yes,
it's
very
important
good
that
point. Very good point. And the recommendations are that if you're under 50 and your periods have stopped for a year, you still have to protect yourself for 2 more years. And if you're under 50, and if you're above 50, then 1 more year after your menopause. So a very good point, Nisha. Please don't be falsely lulled into thinking I'm not going to have a baby, because you can fall pregnant.
And so, Nisha, you mentioned as well, when we're talking about unwanted pregnancy, there are some things that can be done to resolve that. And can you talk a little bit about abortion there, which is one of our other topics today, and what it actually involves?
Yes, absolutely. So abortion essentially can be two ways. One is surgical and one is medical. So surgical abortion was the more common way that most people would have heard of. They would have heard of it as being called a DNC. It's usually a very short procedure. It's a day procedure. It's usually done under either a general anesthetic or what we call twilight sedation, which is essentially putting you not quite under an anesthetic, but putting you to sleep in a sense. And it's done as a surgical procedure. We put in some instruments into the womb and we just empty out the contents of the womb. Most women will go home the same day after the surgery. They will have some bleeding and cramping once they go home. Shouldn't go on for any longer than about 24 to 48 hours. And then they should be back at, doing all the normal things that they would do. But because it is a surgical procedure, it does have certain risks that go with having a surgery. Things like excessive bleeding, infection, causing injury either to the cervix, which is the neck of the womb, or to the womb itself. So those are some things to consider. Plus, it means that you have to leave home, you have to go to a hospital, you have to get admitted, all of those things, which women might want to avoid. And so the other option, which is kind of do it yourself or do it at home option, is to have what is called a medical abortion. What the medical abortion involves is, first of all, it's not suitable for everyone because it can't be done once you are beyond a certain stage in pregnancy. Usually we say that that is about 9 weeks. So when you are 9 weeks or less pregnant, you still have the option of having a medical abortion. It involves taking two sets of medication. The first medication is something that works against the hormone of pregnancy. So it kind of blocks off the pregnancy hormone, which means that the pregnancy then can't grow as it would normally grow. About 24 to 48 hours after that tablet, you take a couple of other tablets. There are two tablets that you put into your cheeks and just leave them there for a while and they get absorbed through the cheeks. What those tablets do is then they start the uterus, get it to start contracting. So essentially, like it would happen in any other situation, the uterus is a muscle, so it can contract. When it contracts, what it does is that it pushes out whatever's inside the uterus outside. And so what it will appear when you do take those tablets is that it will be like having a heavy period. There'll be cramping, and then all of the products of the pregnancy, which are inside the uterus, will be passed out. Women might find that the pain is significant, and our advice usually is to take painkillers during that process. There's no point in putting yourself through that pain if it's not necessary. For most women, this can be done very easily at home. Nowadays, this can even be done over the telephone, what we call telehealth. And so there's a telephone number you can call, and the tablets will all be posted out to you, and you can take them in the comfort of your own home. That way, you don't have to leave the house, you don't have to go anywhere, and you don't have to kind of declare it to anyone. It's all very private, and it's up to you how and when you do it. So all of those, the options are available. The important thing for women to remember is that they are available to everyone. And so you might find, if that is the case, that you go to your GP and your GP says, actually, I don't provide this service. But all doctors have a duty to refer patients to somebody who can provide that service. So if women find that that's what they face, they need to ask. And if they find that they can't get the help, then all they have to do is to go online, because telehealth or teleabortion is available to every woman across Australia, anywhere at all. And so they can access that from their home.
Great, thank you, Nisha. And so I think one of the barriers as well to accessing abortions is cost. And I'm wondering, do you have a sense of how much, a medical abortion is, how much a surgical abortion is, and how much of it is actually out of pocket compared to what Medicare covers?
So the good thing with the COVID, the pandemic, has been that some of this telehealth abortion has actually been brought under Medicare funding. And so thanks to, when we say there are some silver linings of this pandemic, one of those silver linings is that the cost of abortion has actually gone down because some of it is being covered by Medicare. But on average, I think women should expect to spend somewhere in the region of between $400 to $500, and especially for a medical abortion. If they're having a surgical abortion, then that might be even more expensive, because then you have to factor in the cost of hospital admission, cost of anesthetic, all of those things. So somewhere in that region, women will have to be spending money, and it will be different in different places, obviously. And so it's worth actually asking upfront, and there's nothing wrong in asking upfront, how much will this cost?
Absolutely.
Quite a few GPs prescribe the mifepristone and misoprostol combinations now, and Mary Stopes is an option, and we recognize that especially for people that are not metropolitan, rural and remote, the access can be quite a significant problem.
Yes, definitely. And so I guess another thing that may worry women about accessing abortions is the potential sort of health effects afterwards. Is there any lingering health effect, especially if you want to actually become pregnant later on in your life?
So yes and no, because of course, if you need to have, for example, a surgical procedure, we spoke about the fact that surgical procedures can carry certain risks that go with them. One of those risks is infection. And if you have an infection that spreads from inside your womb out into the tubes, then it can cause problems with getting pregnant in the future. But the good thing to remember is that these complications happen very, very rarely. For the vast majority of women, an abortion will be a completely straightforward, safe procedure, which will have no long-term effects on their future fertility or on their ability to carry a pregnancy to term. So women should not feel like they, shouldn't have an abortion because they'll never be able to get pregnant again, for example. That is exceedingly rare to happen. I suppose the other thing that women sometimes worry about is the mental trauma or distress from having an abortion. Lots of research has shown that actually the trauma of having a child that you didn't plan for, didn't want to have, is much higher than having an abortion. And so most women who have an abortion will not have long-term regrets from having the abortion. So women should feel safe if they decide that that is the right thing for them to do at that time.
And we do recognize that, culturally, especially where we're speaking to a culturally and linguistically diverse group of women, which I always say it's my honor and my privilege to look after this group and look after a diverse group of patients. We recognize that any of us might have religious or cultural, it's a very sensitive space. And sometimes even within the family, I find that the partner has a different view and a woman has a different view. At the end of the day, you need to feel empowered that it's your body, it's your decision making, and you will be supported. It's very ideal if your partner and your family and your mother and your sister and your friends are on board, but really you have to focus on you, because at the end of the day, it's your body and you should be in the driving seat of the decision making around your care.
I'm really glad you brought up that point, Talat. That's a really important one, that it's the idea that it's the woman's decision to make, and it doesn't really have to factor in any other person's decision. It's solely her. I think that's a really important message. And we've got
there's a question from one of the participants about what advice we have for women who don't have access to $400 or $500 or more. And I suppose one of the options would be that there are quite a few GPs who provide medical abortion services bulk billed. And so you may not need to spend those $400 or $500 if you are able to access those services, it's worthwhile checking with your own GP and checking with other local GPs. Wherever you live might have a local kind of register or a online registry of who provides abortion services, and you can look for that. There might be a local network, a public health network locally that will be able to give you that information. So absolutely, not everyone has $500 lying around to be able to use it for this. And so there is help available out there.
My other suggestion would be that when you do go for a termination, think through the contraceptive lens as well, because whilst you're there, it's an opportunity, especially if it's a surgical operation, for them to insert possibly the implant that I mentioned, or the Mirena, into the uterus at the end of the procedure, because then you've got to think long term, because generally speaking, we want to avoid terminations if we can. And we're not talking about medical terminations, which are done because unfortunately the baby has been found to have, an abnormal result or an abnormal ultrasound finding prior to. We're talking about, otherwise normal pregnancies, but your psychological well-being is very important as well, and your financial thinking through of bringing up the baby. So we've stopped focusing on just what is medical, and we look at you very holistically. So everything that impacts you is important to articulate it. And like Nisha said, it's a window period, because once obviously the pregnancy gets too advanced, then we basically lose some of these options that we've discussed today. So please reach out early. The help is there to support you.
Mm-hmm. Thank you, Talat. And so just to clarify, what is that final cutoff period when you get abortion?
So that again is a complex.
So the final cutoff period depends on where you live, Amanda.
Mm-hmm.
And so there isn't one answer that fits all states and territories in Australia. The cutoff will depend on where you live. But even later on in pregnancy, there is the option to have an abortion, just depending on what the legalities are in the state where you live and what the options are for late termination of pregnancy.
And unfortunately, healthcare in Australia in certain systems is very fractionated and, like Nisha said, statewide. So for example, in New South Wales, we use 22 weeks as a cutoff to say, look, after that. And these are complex questions around when does a baby become viable? So viability is different. We start depending on what yardstick you use, but from 23 weeks onwards. But I must say, clinically, the more advanced the pregnancy gets, the more uphill it is to actually access a termination. So again, whilst we don't want any coercion on anyone to have to feel any pressure to finalize early, there's still an endpoint, and there's some milestones there that we obviously don't want to cross. And once, if those are crossed, there are other things as well. Some women look at adoption, give up the child for adoption. They choose not to have a termination because it's taken quite a while to make a decision. But just some food for thought. Complex space, but try and please articulate what your thoughts are so that we can. There might be access to counseling that might help you in that. Sometimes it's very foggy and difficult for you to decide what is the right thing to do. And some women feel guilt, and we obviously want to minimize that and work with you with professional support to minimize that, so that you don't have any of those consequences.
Thanks, Talat. Mm-hmm. And so we've talked about abortion being sort of one of the side effects almost of not using birth control. And so another one is STIs, so sexually transmitted infections.
That's right.
Unpleasant topic, but if you could
we are certainly going through a list of taboo topics today. Yes.
Could you tell us what an STI is exactly?
Sure. So STIs stands for sexually transmitted infection, and as the name implies, these are infections that are got through sexual contact. And this could be woman to woman, woman to man, so heterogeneous or otherwise, or it could be via vaginal sex, anal sex, oral sex. So there are lots of pathways through which we can get a sexually transmitted infection. Again, I think the theme of today is prevention is better than cure. Prevention is better than cure. But What do we do when we find ourselves in a situation where there are certain symptoms? That's one question we wanted to address. And number two, generally speaking, sexually transmitted infections are on the rise. And this does not mean all 30 of them that I'm talking about, but in general, a number of them are rising. Now, it may be that we are testing more, and perhaps previously, because a large number of these are actually asymptomatic. So that's another really key point, that please don't think that just because you don't have any symptoms that you are safe from this. It's actually a monster, because it can have short-term consequences, it can have long-term consequences. So for example, the most common sexually transmitted infection that I see, and that is the standard statistic, is chlamydia. So Amanda, chlamydia, 3/4 of chlamydia infections are asymptomatic. So those women will have no clue that they have this disease. Other things, however, that may give clues that something is wrong could be like an ulcer down below in the vulva-vaginal area. For men, it might be penile discharge, or similarly an abnormal vaginal discharge. So you have often it's good to be in tune with your body as to what is your normal baseline, and that helps you identify if some change from that baseline has occurred. So there's just a copious amount of vaginal discharge. Often they'll say it's yellowish or it's greenish, it's a bit frothy, it's itchy. And I've got an ulcer, or I've got some bleeding that is irregular, like especially bleeding after sex, bleeding in between periods, or pain, pelvic pain. And so back to the chlamydia, for example, I'm using that as an example. This is a simple infection to identify, but again, it's a battle both for you as a patient and a woman at the center of our care, and also for our clinicians to ask. Because sexually transmitted infections, sometimes it's really awkward for you to start the discussion, but please, I'd like to normalize this to say, it's in your health interest to say, look, something is going on, something is not right, or I've noticed this new pain. Can you help me figure out? Again, your GP often, the GPs hold so much of the good ability to change the trajectories for women in this space, and they will organize to review you, to examine you, to take a good sexual history. And again, I would say, please don't be embarrassed. I know I always say we're so nosy in this profession, but that is why, because we're trying to actually assess what your risk factors are. For example, are you in a new relationship with a new partner? Have you got multiple partners with unprotected sex? Have you had an STI before? Have you had, are you going to have a procedure that might flare up a STI, like for example, if you're going to have a termination, or you're going to have an intrauterine device put in. So these are the kind of questions, the difficult questions we ask, but please understand that they are in your best interest for them to be asked and to be answered honestly. And sometimes, obviously, women are very embarrassed that they have got a positive result. Please don't be, because this is an infection. It's like, I know it's trivializing by saying it's like the flu or it's like any other infection, but honestly, the best way to address it is to say, look, how do I minimize this? How do I treat this so that it goes away? How do I minimize spreading this? And this is not only between you and your partner or partners. This is actually a bigger ethical discussion about our community. So how we react when we find a abnormal is actually going to long-term impact on what our transmission rates are, what our community prevalence of these diseases are. So I would encourage you, one, to try and prevent it using condoms. Two, to realize you can still have STIs even if you don't have it. So please screen if you're in a new relationship, screen if you think you have any high-risk behavior. Thirdly, if you have symptoms, please get tested. The tests are easy. Most of them have things that we can do in that space to help you. Most of them are treated with antibiotics. This is the bacterial ones. Then obviously there's some bloodborne ones and some sexually transmitted viral infections as well. So it's a wide range, but I didn't want today to just list infections for you. I rather wanted to focus on what you can do to minimize this and to help yourself when you do get one. Then there's a very important concept of contact tracing. So when you actually are tested positive, your clinician or practitioner is likely to ask you, who have you had unprotected sex rate. And most of the times we go back in history 6 months. And sometimes you may not know, and that's fine. In terms of we're not able to obviously trace if there's been sexual activity with someone you don't remember, but many times you do. And if you are too uncomfortable to have that discussion, the GP can have the discussion. The GP, there's also some websites called Let Them Know, so which they actually contact the partner and say, look, they don't get into the complexities of who told them that you remain anonymous, and they say, look, you need to get tested for example, for gonorrhea. So there are ways that you can remove yourself from the equation, but still do the ethical thing by making sure that the contact tracing is done. And then obviously, like I said, there's some long-term consequences we're trying to prevent when you've got an STI. So chlamydia, for us as an example, can give you damage to your tubes. So this is my little model. Inside that, I don't know if it's that easy to see. It's probably not a very good one to show the tube, but this is the uterus. And the uterus is connected by the tube to the ovary. And as we know, the ovary releases the egg, but the job of the tube, which connects the uterus to the egg, is to transport that fertilized egg to the uterus. And if that tube gets damaged on the inside, we can get something called infertility, which means that when you do want to fall pregnant, it might be a bit of a struggle. And number two, we can get an ectopic pregnancy. So pregnancy can implant in that abnormal tube. And some women can get what we call chronic PID or pelvic infection disease, which means that instead of that chlamydia just remaining in the lower part of the uterus, it's actually going into the actual, into the actual uterus and this, all of these, and sometimes even outside into the pelvis, and all of this is angry and inflamed. And they can have long-term consequences. So please don't underestimate STIs. Get tested, including testing for hepatitis C, HIV. So whatever is the relevant context, if what person gets one, we try to test for everything to make sure we're not missing something else, because it is very possible to have 2 or 3 STIs at the same time. I think that this is a space that a lot can be done into traction. Thank you, Amanda.
Thanks, Talat. And so how often should women get tested for STIs?
So we do say that under 30 is a risk factor. So when you do, and we encourage clinicians on the other side of the curtain, we encourage clinicians to do what we call opportunistic testing. So if, let's say, someone just presents for cervical screening, or for some other reason, or is pregnant and has, a reason, so under 30 is a high risk that we focus on. Then, of course, like I mentioned, if you've had a new partner, if you've had multiple partners, if you've been injecting drugs, any high risk behavior is basically a catalyst to be tested. We also offer testing to anyone that asks for it. So you can actually go in and say, look, I want to be screened, and you will be screened for STDs. The other one that I wanted to particularly mention is a virus called HPV, which is human papilloma virus. And this is the part of our cervical screening that we do, and which is a slightly different context, but it is an STI, it is sexually transmitted, except that it is very common. So when we there are more than 100 types of HPV, but the 3 that we are obsessed with, or the ones that we are obsessed with more, are the ones that are called oncogenic ones. And you would have heard of a cervical screening test that is done every 5 years in Australia. We're trying to see if a woman has that when we examine the cervix by the lab. And if that is tested positive, then obviously there's certain things that we do in that space. But that's another virus that we are trying to minimize people carrying by encouraging vaccinations. So another question I commonly get asked is, should we let our children get vaccinated? And I would say to you, most definitely yes. This vaccination is quite safe for HPV. It is offered in our schools as part of the National Immunization Program. And it basically has been one of the biggest success stories in medicine, minimizing cervical cancer, both from a robust cervical screening program that we're so lucky to enjoy in Australia, and also from the prevention used by, so we are hopefully having a younger cohort coming through that will not have the misery of the rates of cervical cancer that, previously have been seen.
Great, thank you. But we've got a question coming in about why is under 30 considered that sort of risky age? Is it due to like the general risk-taking behaviors of young people?
To be honest, STI can occur in any age group, and honestly, I diagnose it every day in all sorts of ages. So I don't mean at all to be ageist, but just because younger people are more likely to have unprotected and multiple partners, so we're just mindful, and because they have often at the same team that haven't had children or want more desire, more fertility. So there are a number of levels on which they get priority, and simply it's because they are more likely to test positive.
Great, thank you. Nisha, was there anything else you wanted to add about STIs?
Yes, just in response to the question about why under 30. So it is definitely not a under 30 thing. You know, increasingly we find that women in their 40s and 50s, for whatever reason, a long-term relationship breaks up and they, you know, are experimenting and going out and looking for new life partners. And those are absolutely situations when women should get tested for STIs, because we are equally vulnerable at whatever age we are when we step out of a long-term relationship and into new relationships. So that context is really, really important. And in terms of testing for STIs, another opportunistic time to test is when you are planning a pregnancy. It's always a good idea to plan a pregnancy, to make sure you're in the best of health before you get pregnant, and to see your GP to make that plan for when you get pregnant, to start the folic acid, start all of those things. And at the same time, have screening for an STI, so that if something is found, we can treat it long before you get pregnant, so that the pregnancy itself will be a safe and positive experience.
That's right. And one other thing I wanted to add, Amanda, is around, Nisha rightly reminded me, is around that unplanned pregnancy, that if you've had unprotected intercourse, and basically one of the other options of contraception is emergency contraception. And so in that space, we have three options. There is a common medication now, thankfully, is available above the counter called uliprostate acetate. And so it's a tablet that you can have, and ideally you should take it as soon as possible after the unprotected intercourse option. And some women choose to keep it at home as a just in case, but you can use it up to 120 hours, which is about 5 days afterwards. But the risk of you actually falling pregnant goes up progressively in that time. There are other medications that you can use to try and, say, hey, unfortunately, I've had this unprotected intercourse. I don't want to fall pregnant. Can I do something now? I wasn't on any contraception earlier, or the condom broke, or I forgot to take the last 2 pills, or there are a number of situations in which emergency contraception is really helpful. The other thing is that one of the intrauterine devices, so I mentioned Mirena, which has the progesterone, but there's a copper-based intrauterine device, which can be used by women anyway, but is particularly good in this context. If you've had unprotected intercourse and you're like, oh goodness, what do I do? We can actually offer that if suitable, if there's not other risk factors around STIs, because sometimes you don't want to introduce an infection in that space. But that can also be a really good emergency contraceptive option, and obviously then remains in longer term as a contraceptive option for you.
Thanks, Talat. That's really helpful. And so the morning after pill, that's something is sort of an emergency, as you said, right? That's something that women shouldn't be regularly taking, right?
I can't discourage that because, again, what it means is that you're not reaching out for a solid system. We're trying to band-aid the issue rather than actually, but another way of looking at it is we're actually weighing up a pregnancy, a potentially unplanned pregnancy versus, nipping it in the bud. Because, for example, this UPA that I mentioned at the morning after pill, what it does is that it suppresses the ovulation, or it delays the ovulation. It makes the ovary actually not release the egg, generally speaking. That's one of the mechanisms by which it acts. So again, the more timely you use it, it's about raising the health awareness, Amanda, which is so good that, with this initiative, but in general, raising health awareness that this is available. Many women don't know that there's a contraceptive option. And now, thankfully, we don't need a script, you don't need to see a doctor first, get a prescription, which was multiple barriers to accessing this, whereas you can get it above the counter. But like I said, hint, hint, if you think that you're going to be in that position, ideally you should consider perhaps a long-acting contraceptive. That is one of the very stable options. But if that is not for you, then at least keep some for a rainy day if needed, because studies show that women who have more timely access to it fare better than those that have, waited the weekend and said, I'll get it on Monday. And, those kind of situations are less ideal. But the thing, Amanda, with contraception, obviously, is that we have to find, it's almost like trying to find the Goldilocks version for you. And so, for example, the pill has a slightly higher chance of with clots of the legs and the lungs and all that. So we need to know that, if you have a family history of clotting, or for example, if you're hypertensive, high blood pressure, you may not be suitable for the pill, or you're above 50, or there's certain, we're trying to get the perfect match between you, what you want, obviously, like I said, you need to articulate what is important to you and what options are available to you. So I try to make it a two-stage thing whereby we provide a lot of information and then we say, look, think about it, let us know which one you'd like us to help you with, and then for the woman to make an informed choice as to which option she wants to choose.
That's great advice, Talat. I think that's really important for people to remember. It's about getting that information and then later making a decision. You don't have to decide on the spot as well for something that is has a drastic impact on your life as well. So that's really important to hear. Yeah, so Nisha, you touched upon this earlier about different lifestyles that women may choose to engage in after a relationship, for example, and that does have a little bit of relevance to our final topic, libido. So this is something that was by popular demand, and it's something that I think we don't really talk about outside of, friendship groups or women's magazines, but it's really important to understand that sexual drive is a very normal thing, and it's important for us to talk about it today. So Nisha, maybe you can start things off by telling us what exactly is libido.
It's essentially your sex drive, your desire to have sex. It's basically that. But what happens is that there are two components. There's a desire to have sex, and then there is the actual sexual act. And if the actual sexual act doesn't give you pleasure or actually causes pain, then that drives you to have less of a desire to have sex, which is a very natural thing. We all want to avoid experiences that are painful, experiences that are not pleasurable. And so that is not surprising. And so it's important to make that difference of whether is this just related to a drive, or as in, wanting to have sex, or is it actually something to do with the fact that sex itself is painful, or it is, a process which just causes you discomfort. So getting that sorted first, I think, is a very important thing. And sometimes it's very difficult to make that differentiation, because it then becomes sort of like a vicious cycle. You may have the desire, but every time you have sex, it is either uncomfortable or not pleasurable. That drives you to have a less of a desire. And so then that cycle just continues.
Yes, thank you. That's really helpful to know. I guess what I'm wondering is what actually can affect sex drive? Is there some behaviors? Are there like diet, for example, lifestyle?
There are lots and lots of things that can affect libido. Lots of things, right from diet, lifestyle to actually medical conditions. But again, one of the important things to think about is how does one define what is normal? And often as a society, we are defining it based on a comparison. We are interested, women's magazines are talking about this woman's having sex every day and that couple's having sex every twice a day. And that makes us judge our own sex drive based on somebody else's sexual activity, which is wrong, because we're all different individuals. Each couple's relationship is a different relationship. And so defining what is normal can't come from a sort of, there isn't a fixed standard that you must be doing this every day for it to be considered normal. So whatever is normal for you is normal for you. Ultimately, what is important is there an imbalance between your sexual desires and the sexual desire of your partner? because that is where the problem arises. If you both have the same kind of sexual desire, then it doesn't matter whether it's once a day, 3 times a day, or once a week. You both are doing things to keep each other happy. Whereas if you'd want to have sex once a day and your partner wants to have sex once a week, then that's a problem, because that is what will cause that differentiation and make you feel like your partner has less of a sexual drive than you do. And so it's important to tease out those sorts of things of what the issue might be, but thinking about what conditions can cause it, absolutely. Actually, physically or clinical conditions, things like endometriosis, having pelvic infections, having a prolapse either of the uterus or of the vaginal walls where there is actual descent of the uterus into the vagina, any of the STIs, because they cause discharge, they cause discomfort, things like chronic pain. So any condition that is associated with chronic pain, if you are in pain, you are not going to desire sex. Let's be very clear about it. And so those are the sorts of things that can affect sort of the physical side of it. Other situations like being hypothyroid, so having low thyroid hormones, being anemic, having other conditions, having stress in your life, all of those things will then affect how you feel about life in general, and then will affect your desire to have sex. It's also important to recognize what sort of a relationship it is. A relationship that is loving and trusting and complementary is a sort of relationship in which that sexual desire continues to exist. Once that relationship changes, so for example, I have seen women where the partner has, both partners have a sexual desire, but one partner is telling the other one, oh, look, you put on so much weight. Now that is going to affect your assessment of your own physical self, and is going to affect whether you want to have sex or not, because you're not going to want to do it because you feel judged all the time. And so there's so much more to libido than just the sexual act and how many times it's done.
Yeah, and Amanda, another very well put, Nisha, but another time is when women have just had a baby. So, you know, the baby's actually keeping them up at night. They may be breastfeeding. The breastfeeding, actually, you have lower estrogen levels, and your vagina also might be recovering from a tear, and can be genuinely, you might have dryness down below and just not be interested because you're balancing so many things in that space. So again, I think quite rightly, and again around the menopause time, I feel that women complain about this both as an organic reduction in libido, but also as a reflection of the stresses they might be experiencing in that space. And thirdly, because the low estrogen levels have led to, you know, that whole area becoming more fragile and more what we call atrophic, which means just thinner. And so the vagina, the friction of sex is actually uncomfortable. So although we're talking about libido, which is the desire, it is quite rightly, like Nisha said, a very complex space as well, because we are talking about, well, why has your libido changed? Is there other external factors that are contributing to that, or is it an internal thing? And sometimes the medication, women are on antidepressants, are on different medications that might actually inherently affect their desire to have sex. And interestingly, even with the contraceptives that I've been speaking about and saying, look, these are really good things, they do have side effects. And some of them women articulate to us that, look, my libido has changed and I don't want this one. Can I try something else? And so we try to work with them in that space to work out what is the best fit for them. But in addition to obviously all the other, you know, like for example, some women have irregular bleeding, or they have, you know, they might feel acne or not have acne, or different sort of side effects that they report to us. But this is one of them, a change in libidos depending on different life stages of their life and what they're using.
And the sex drive for all of us is driven by testosterone, which is actually a male hormone. It's traditionally the male hormone, whereas women's hormone is the estrogen. But what we forget is that our ovaries actually also produce testosterone, which then drives sexual desire. And as we get older, as we get closer to menopause, as our ovaries, you know, sort of reduce the production of hormones, they reduce the production of testosterone as well. And so that is one of the reasons why when you get older, so there's all of the other stuff like the, the delicacy of the tissues and all of those things, but there's also the fact that our ovaries have stopped producing that very essential hormone which drives sex.
That's right. And also there's some cultural things I find that certain almost like cultures, they feel, oh no, I've had the babies, now I don't, need to. So they may actually be what what their mothers-in-law, aunties, people who have shared with them in that space. So again, I would say to you, this is a very personal space. You need to find what works for you. Again, your GP is a port of call. As a gynecologist, we often see this situation. We try to work out all the organic causes, but there's sexual health physicians as well that are really good in this space. There are counselors, they have physiotherapists who can actually help. Sometimes they use dilators, they have different equipment they can help you with. And after identifying where the pain or the discomfort or what, especially if there's some organic, obvious pathology that we can help with, like endometriosis or something that is, either causing the physical pain, and so therefore you're getting a secondary anxiety around the sex and that's affecting your libido, or whether it's just genuinely you just don't feel like having it, which is another type of reduced libido. And sometimes the other way around as well, some women just feel they want to have too much sex to the point that it's, very dysfunctional for their lives. They have identified that as a problem. And like Nisha said, especially if it's not matching who they might be wanting to be compatible with, it can be a big source of disharmony in a relationship.
And culturally, we are brought up almost to have this shame reaction to sex. And so if we have either a high libido or a low libido, it automatically connects us to a very uncomfortable place where we don't talk about it because we feel the sense of there's something really awful or bad or shameful about it. And I think that then plays into the whole situation in a negative way, where it drives all of the thinking about it further and further.
Yes. And in that space, like Nisha said, you could be comparing yourself to others, but also if you find good friends, good connections, all the things that we've talked about today, if you're well connected, whether it's by social media through a WhatsApp group or some group that you're connected with your friends with, or it's a mother's group, it is really important to find those safe, secure, and comfortable connections for yourself as we journey as women through different interfaces and through facing sometimes complex curveballs that get sent to us. These are helpful to build those relationships if possible. Sometimes it's not possible because we're in relationships that we, or we are in circumstances that we can't control. But even then, I would say, please articulate, please seek help, please trust your GP. The role of the GP and the health practitioners is there to support you. There are other people, social workers, and so many people that are geared towards working with you in that space, midwives, nursing staff. Lots of people can be your allies if there's any issue that we can help with.
Great, thank you, Talat. And so we have about 5 minutes left, and I'm wondering if there are any questions from the audience, please put them to the chat. Something I was wanting to ask is, so we talked a little bit about some of the misconceptions around women's libido, and I don't know if you've noticed this, but there's also a lot of ads that are sometimes saying, oh, eat this fruit and see your drive increase. And so, misinformation out there as well on, the certain properties of certain ingredients of foods. Is there any scientific basis to any of that?
Look, I think certainly some aphrodisiacs, but I think the internet has done a big disservice to many people. We always try and see if you can go for a regulated industry, which is under TGA or, through a reputable pharmacy or a reputable website. A lot of people are just making money and they may be convinced that what they're selling is thing, but really there's very little research to back that up. So many of those ads are just shams and they're ways that people are just scamming, unfortunately, vulnerable women at a time that they want to seek for help, but they're just seeking for the wrong help.
But if you do want to look at things like naturopathy or, look at natural options, go to a reliable place. One of the reliable places for information is the Jean Hales Foundation. all online available, and you'll be able to look at, in fact, they've got a whole section on menopause and herbs and naturopathy and libido. So have a look there to see, so that you get reliable information rather than information of dodgy internet ads. And lube is your friend.
Lube is your friend. Now, on that matter,
it doesn't have to be fancy, branded lube. Any lube is your friend.
And please note that oil-based lubricants can sometimes encourage the condom to break. So it's better to go for water-based lubricants. But Nisha is very right that lubricant might just be the solution to help, or be part of the solution to create a less friction-based sex and reduce your anxiety, because oh, okay, at least I'll be moist down below and I'll be able to manage that as a patient.
Perfect.
And explore your own sexuality. Don't be ashamed of it.
I think, Nisha, you've got a certain prop there.
I do have a certain prop here.
Yes, we've been talking about very typical sexual scenarios, but there we go. We've got more in your toy box tonight. Yeah, the marine and the implement.
So thank you both so much for sharing all your various props and your information. This has been so helpful. And I'll just remind everyone that we are recording this. So we'll have clips up on the Harmony Alliance website, as well as the RANZCOG website, if you want to rewatch anything. And I'll also mention that this is an ongoing series. So we'll have another webinar out in December where we'll cover different conditions common to women, like endometriosis and fibroids, a lot of different things. So every webinar will cover a different topic. But thank you so much to our speakers today. This has been so good and so interesting.
Thank you, Amanda. Thank you,
you.
Nisha, and our participants. Thank you very much for this opportunity. Bye.
Thank you.